So in this section, I'm going to be talking about the nuts and bolts of how to use EMDR to treat chronic pain and medically unexplained symptoms. Now, I'm assuming at this point that you've seen the introductory video covering the history of pain and medically unexplained symptoms going back to Piaget and Charcot, coming up to the present and increased acceptance of the role of traumatic stress in maintaining pain since the turn of the 21st century, increased understanding of the role of brain processes in maintaining pain, and why all that supports the application of EMDR for chronic pain, and a brief research review. Just before we sort of get into it, I want to tell a quick story that I read recently about one of Milton Erickson's pupils who asked him how he treated chronic pain. Now, of course, Milton Erickson was one of the greatest hypnotherapists, if not therapists, of the 20th century. And like any good teacher, Erickson rarely answered such questions with a straight response. He always answered with a story. And how he replied to that student's question was both surprising, effective, and simple. He answered by telling a story about a man who had terrible chronic pain, who spent all day in bed thinking about his pain, until someone put a tiger in his bed. You can imagine what effect that had on the man. But just to make sure, I'm going to share with you 4 key takeaways from that story, that silly little story that answer the question about really what I'm here today for and what this is all about. First of all, Erickson told a story which makes the listener figure out the answer for themselves, which is really what all of our patients have to do in the end. We don't fix them. Our job is just to help them find their own healing. Secondly, stories are activating the right hemisphere, which is the antidote to left hemisphere thinking, which is really what is associated with so many trauma survivors' attempts to cope. Most trauma and pain management is actually about deactivating the left hemisphere, whether it's hypnosis or EMDR or somatic therapy. Thirdly, the point of the story, in case you missed it, was the idea of helping the sufferer focus on something else other than their pain. And that's essentially how Erickson overcame his own post-polio pain, by focusing on something else and the elements of confusion and surprise, which, when you think about it, happens a lot in EMDR, because who thinks that focusing on their problems and bilateral stimulation, that can have anything helpful about it. Lastly, the idea, and this is very important, of creating a new experience is core to therapy. Therapy is about creating new memories and based on new experiences. And Otto Rank, a pupil of Freud's, said this nearly 100 years ago. And he felt that therapy was much, much more about creating experiences in the present and the therapeutic moment than exploring the past. Associated with that, Rank saw the client as a creative agent and the therapeutic moment as an opportunity for change. So I'm going to quote occasionally from Freud and Rank and Genet and Charcot, and I'm not actually particularly psychoanalytically oriented, but it is an element of EMDR therapy, just that idea that you're making connections between the past and the present, and new learnings associated with different experiences that a person has about themselves. So unexplained pain or hysteria and the idea of unprocessed trauma being held in the body used to be the central problem of psychology. And then pain got taken over by the medical profession. which is still where most of us look for a solution, even though medically unexplained symptoms affect 1 in 5 people, and that over 60% of complaints at primary health physicians are never actually diagnosed. So trauma and pain are inseparable. So this is just a quick overview of what we're going to cover today, notwithstanding what we're going to cover tomorrow, which is adjunctive strategies. So we're all familiar with the basic trauma protocol, and as with any different application of EMDR, whether it's for pain or anxiety or depression or addictions, there are variations. But we start out with that familiarity with the basic trauma protocol, the AIP model, the 3-pronged 8-phased approach. We're also coming from a point of view where we're really looking for traumatic antecedents of current presenting problems, which is actually a very old idea, but is in some ways it was lost in the 20th century with the ascendancy of behaviorism and CBT. However, I'm also going to show that it's not enough just to look for past trauma, personality, not just what happened, but who it happened to, and we'll be looking at why that's important. Are some people more sensitive to trauma and pain than others? And treatment planning. When and how and with whom should we use EMDR? What do we do differently during the processing phases to address the unique demands of chronic pain and medically unexplained symptoms, especially where they're associated with a history of trauma? Resourcing. What's the role of resourcing? It's an essential element in the treatment of trauma, but in the treatment of chronic pain, it goes way beyond just safety and containment. It extends, right through the treatment process and into really the creation of future templates to help clients manage ongoing pain, which many chronic pain sufferers will have following EMDR. And then last but not least, the goal of treatment is integration. It's more than symptom management or relief. It's about helping create a fully functioning, integrated person, where their mind and their body work together, where the different parts of their personality structure are aware of each other and working together harmoniously. So the therapeutic agenda, is about, facilitating a whole healed person rather than just symptom relief, which it can be tempting and easily to get sucked into because, that's what so many clients are demanding. There are 2 things I want you to remember as we're going into this. One is that you're usually dealing with a combination of physical injury and trauma, just of varying percentages. And so that regardless of what injuries or illness the person may have suffered, there is nearly always a component that is dissociated emotional distress. And this goes right the way back to Piaget and Charcot and hysteria. So this idea that the body remembers, whether it's the vaginismus of an abuse survivor, the headaches of a conflicted survivor of emotional abuse, the whiplash pain of a motor vehicle accident survivor, and so on. Just bearing that in mind. And the second point is that pain can come not just as a result of trauma, but also because of the damage that years of living in a fight-flight state has on the nervous system. It's about damaged immune system functioning or physical health, perhaps as a result of years of trauma, neglect, stress, and all of that predisposes a person to chronic pain following injury or illness, or some relatively minor insult that is just enough to tip that exhausted and damaged nervous system into a chronic pain state. It's kind of like Pavlovian conditioning. The constant drip, drip, drip of danger, lack of safety and support, having to deal with unpredictable circumstances, having to be in a fight-flight response all the time. So very few clients in this arena are simple cases of textbook trauma and pain. Most sufferers of chronic pain or medically unexplained symptoms are suffering from a combination of childhood neglect, abuse, big and little t trauma, and multiple health problems. And it's that constant barrage that leads to the central sensitization that maintains chronic pain. Now, there are a number of EMDR pain protocols for different kinds of pain: phantom limb pain, non-traumatic pain, headaches, somatic symptom disorder, and so on. I immediately saw the potential for pain when I first learned EMDR, but didn't really know how to go about it. And I must acknowledge at this point Bruce Eimer's early work with EMDR and the treatment of chronic pain. And he published an article in the EMDR newsletter in 1993, which really helped me to get started. For personal reasons, his work was interrupted, and he's now more known for his work with hypnosis. He also takes an integrated approach incorporating IFS, that's internal family systems, and CBT. But I think both of us agree that EMDR is really useful for that aspect of pain that's coming from trauma. The good news about all the different EMDR pain protocols is they're actually quite similar, and they all really involve three key features. One is, whether they're targeting pain, trauma, or the effects of pain. The second feature that's common to all EMDR protocols is that they usually involve an integrated approach. So, for example, Marcus's headache protocol incorporates breathing and head compression. My integrated approach incorporates hypnosis, ego state work, and somatic psychotherapy. I don't know why I've got psychosocial there. I guess it is a psychosocial approach, but it's as you'll see, the emphasis on what's happening in the body in EMDR and in general. And lastly, all EMDR work, unless it's a very simple, straightforward trauma pain case, is usually part of a broader treatment plan involving not only different psychological treatment elements, but adjunctive treatments, whether it's physical rehabilitation, exercise, diet, medical inputs, and so on. So this is just a bit of a heads-up summary of the key variations in the EMDR pain protocol, between that and the standard trauma protocol. In the history phase, it's the obtaining of a health and pain history, in addition to the usual, looking for the usual trauma. In the preparation phase, it's really about assessing the person's current health status and the need for resourcing, which is often about addressing fatigue and lack of energy. In the assessment phase, it's about targeting, whether it's going to be present pain, and in that, constructing the target a little bit differently to how you do it with trauma. So that might involve substituting sensations for emotions in your TICES, and changes in the negative and positive cognition themes and setup, which I'll be covering in more detail as we come to that. In the desensitization phase, two of the big differences are the use of continuous auditory bilateral stimulation. And again, I will talk about that in more detail and why that innovation is indicated. In the body scan, it's really important to track and facilitate the effects of bilateral stimulation much more actively, and taking a kind of a facilitating role rather than just relying on what do you the client's responses to the question and what do you notice now. And in the resourcing phase, it's the utilization of hypnosis to create future templates or resources for helping the client manage persistent pain, and also the use of accompanying EMDR with ego state work to address the structural personality factors that may be maintaining pain and stress. Now, we all know that EMDR is an integrative approach. It's not a cookie cutter, as Francine Shapiro used to say. But in a way, there's a bit of a contradiction there, because I think sometimes just the way it's taught, EMDR is taught, and the reliance on protocols can give it a bit of a cookie cutter flavor. And, along with that emphasis on fidelity and research. I read something or heard something recently that in actual fact, most EMDR therapists' level of fidelity is around 70%. So we're not very few of us are really doing it 100% by the book. Secondly, I think as associated with that I want to say that EMDR treatment of chronic pain involves much more than just the 8 phases and the 3 prongs. It involves pulling in psychodynamic elements, addressing trauma and conflict, somatic psychology, hypnosis, ego state work. Although there's been attempts to separate and distinguish EMDR from hypnosis in the early days, trance is everywhere in therapy, including EMDR, both as a conduit to target material and part of resourcing, and as a byproduct of reprocessing. And again, you're going to see how that plays out as we go along. Even Bessel van der Kolk described his first experience of EMDR as a hypnopompic experience. Finally, when treating pain with EMDR, it's nearly always part of a broader treatment plan. So just to talk about what's different in the history phase, it's the importance of taking a full health history, really, including what injury or illness might have occurred or be associated with the onset of the pain, how long the person's been in pain, how it's affecting their life. And this is all on top of the normal trauma information that you'd take. Medical treatment issues, so how much treatment the person's had, especially if they've had multiple surgeries, which is associated with increased risk of PTSD, whether there's been mismanagement, which is not uncommon in the case of chronic pain. Not that doctors mean to do the wrong thing or hurt people, but unfortunately, when they can't explain why a person's not getting better, there can be a tendency to blame the patient, and this only adds to the trauma of whatever health problems or illnesses the person may be suffering from. So trauma can come from not only the usual sources, but also the injury and the illness that the person has incurred. And then, of course, there is the usual suspects in terms of attachment problems. In the preparation phase, really the thing to look out for is safety issues related to treatment and the effects of the person's chronic pain. If a person doesn't feel that the pain is adequately managed, that is a safety issue. If they're not happy with the treatment they're receiving and feel unable to communicate about that with their treating professionals, those are safety issues which are unique to chronic pain sufferers. Lastly, but not least, is in the assessment phase is your EMDR targets. You have three core options really, and that is trauma if it's related to the pain, which really, in my experience, there is trauma, but it's often, and unless you've got a very simple case of trauma and pain, say whiplash pain or something, it's the often relationship between, say, early childhood trauma and adult chronic pain that's a result of, a back injury or something. It's much more complex and is, mediated by many factors. So you might need to target present pain or the effects of the pain before actually being able to, work with those early trauma that may be associated with the chronic pain. In your case conceptualization, these are the key elements. Okay, so it's not just the trauma and the medical history, but also going to look at the personality. Who, not just what happened, but who it happened to. Dissociation, one of the key factor in the production and maintenance of chronic pain and medically unexplained symptoms. Current life circumstances, often a big issue for people with chronic pain because of the disability. They may not be able to work, they may have financial problems, and they may just not be able to keep up with their responsibilities as a parent or as a partner. And all that creates immense stress, which inhibits your ability to work on trauma and pain management. What resources do they have? Where do you start? So when I take on a new chronic pain patient, these are the 8 questions that I'm seeking the answers to. And these are not questions that I might ask explicitly necessarily. My style is to prefer to let the patient tell their story in their own way, in their own time, and I just sort of gather that information and fill in the boxes as I'm going. Only at the end of that, if I haven't got everything that I need, will I ask those questions explicitly. But mostly I'm trying to gather it subtly and kind of almost non-verbally. And really the end result of it is, really what is this person ready for? Where are they ready to start now? And that's something that really only you as a therapist can decide. Even though they might be saying, I want, relief from their pain, how ready are they to actually do what's necessary to achieve that, or what do they need in its place? And hopefully, through this workshop, you'll see how I do that. Now, clients don't come with a barcode, but these are the 6 kind of etiological factors that you're looking for and measuring in your case conceptualization and history taking phase. And they are chronic pain. Yes, that's why they're coming to see you. Whether there's, simple or complex medical history associated with that, often is not as complex. And whether their trauma history associated with and in addition to their pain history is simple or complex, again, more often than not, it's complex. And looking for the presence of attachment disorders. And again, very few cases where there aren't attachment disorders. And so those are the 6 key etiological factors. I haven't included, dissociation or PTSD diagnosis and things like that, because those are more effects of trauma and pain. But those, knowing, really having a sense of the contribution of those 6 factors will inform the kind of treatment that you're going to use, and I'll explain to you that a bit more shortly. So, of course, there's two primary types of pain: acute or chronic. Acute pain being that what's associated with injury, chronic pain, pain that's by definition lasts longer than would be expected for the type of injury the person has suffered or doesn't have a medical explanation. Beneath that, there are three broad categories of pain. Nociceptive pain, which is that associated with injury; neuropathic pain, which tends to develop when the injury hasn't healed and the pain persists; and functional pain, which is the psychological component of chronic pain. And the thing to say here is that by the time someone's been in pain for more than 12 months, there's usually, you'll find all three elements are present to some degree. So it's not necessary to go chasing down rabbit holes of assuming that all medical investigations have been done. You can kind of safely assume that there is a neuropathic component and a functional or emotional component to the pain. And that's really good in a way, because that's the bit that you can work with. And these are just a few examples of nociceptive, neuropathic, and functional pain. So, for nociceptive pain, for example, that would be something, pain that's associated with mechanical low back pain or post-operative pain. Whereas neuropathic pain is something like allodynia, which is sensitivity to touch, or neuralgia, or chronic regional pain syndrome, or phantom limb pain. And there is overlap between these pain. Then in functional pain, you're looking at things, like fatigue, paralysis, irritable bowel syndrome, gastrointestinal pain, and so on. Most chronic pain sufferers or clients with medically unexplained symptoms will be experiencing one or more of these conditions, diseases of stress. The thing about diseases of stress is that they can affect any and all bodily systems, from the stomach to the heart and lungs to the thyroid, and that they rarely occur in isolation. So, for example, if a client, his main presenting problem is fibromyalgia, it's quite likely that you'll find headaches, irritable bowel syndrome, fatigue, and so on. If there's hypertension, it's often associated with obesity and diabetes, and so on. And these conditions may or may not be associated with some other identifiable medical problems, such as a back injury or you name it. The thing to look for is that the client might complain of fibromyalgia but not mention those other things. So do be curious about getting the full picture. And the more conditions they have, it's kind of a marker for just how badly affected by stress they are. So as EMDR therapists, we are trained to look for trauma as a potential a cause of current presenting symptoms. And the usual kind of trauma we're looking at, physical or sexual abuse, assault or rape, or emotional neglect and attachment issues. But when you've got chronic pain sufferers, particularly where there's been a medical diagnosis and extensive treatment and involvement with health institutions, you're going to find trauma that's associated with that. So just being diagnosed with a life-threatening illness, for example, or multiple surgeries, and medical mishaps, which happen much more frequently than you'd be probably expecting. The other thing about medical trauma is that it tends to be covered up. No one wants to hear about it, and so clients who are recipients of that are often voiceless, and that, of course, exacerbates the trauma. So do be curious about the client's involvement with medical institutions and any problems that may have occurred there. So as this cartoon illustrates, it's very common to hear recipients of medical treatment being told, well, the operation was a success. Don't know why you're still in pain. You'll just have to learn to live with it. And just to give an example of a sort of mismatch between clients' experience and reality and kind of response of the health system, I had a client recently who developed low back pain and was not, the sort of doctors were initially unable to find any explanation, and she was basically dismissed, told that there was nothing wrong with her, and of course that had the effect of making her doubt her own reality and her experience, and also feeling like it was her fault that she was in pain. Eventually her doctor did tell her that she had fibromyalgia and that there was nothing they can do about that. Her chiropractor apparently even told her that she had bad karma. A family member told her that he dreamed she was dead. By the way, vulnerable people are more suggestible hypnotically. That's a fact. So if you're feeling unwell and vulnerable, and people are telling you all these negative things about yourself, you've got less defenses against it than you normally would. Anyway, so she concludes that there's nothing she can do, and she actually gets angry at herself every time she has pain and forces herself to do activities that actually exacerbate her pain. This just makes her feel worse, of course, and she comes to feel increasingly scared and alone, and that she just has to live with this secret, this dirty secret that she's in pain. And in EMDR, we target her feeling that there's something wrong with me, not only physically, but also in terms of, her identity. She starts to feel less ashamed and less judgmental of her own body, and she starts to recover a bit of self-trust. She realizes how she got mentally tied up with the way, people were responding to her condition, and actually starts to relax physically in her body as some of that tension unravels. And she realizes that it's up to her to take care of her health, and that there are things that she can do, and that she has to be kinder and more compassionate with herself. She starts to feel more empowered and becomes more assertive with the doctors, and realizes that she has to listen to herself and stop hurting herself. And you're not just looking for big T trauma. A lot of chronic pain sufferers have suffered multiple small t traumas that in and of themselves wouldn't be traumatic, but cumulatively they are enough to produce PTSD-like symptoms. And often there is big T trauma in there, as the following case illustrates. So this is a timeline of a woman I treated recently who has suffered lots of little stresses in her life, beginning with emotional neglect in childhood. Not at an abusive level, perhaps, but there was just there was emotional deficiency there. Her parents were just focused on surviving. They grew up in a poor area of England. Then the family migrates. She has to adjust to life in a new country, and just in her early teens, there's bullying at school because she speaks funny. She eventually leaves school and gets a job, gets married, just normal life things. But she's doing all of these without really any support because of the effects of her emotional neglect and abuse. Eventually she develops some sort of symptoms of headaches and fatigue. She gets because she's overworking herself essentially to survive. She works as a nurse, drops a patient, basically collapses and falls onto her, and she collapses onto the ground and injures her back. She develops chronic pain. She has multiple surgeries. The treatment doesn't work out. And there's also prior to her work injury, she had a pelvic mesh implant, which, unbeknownst to her, was causing low back pain. It's now the whole thing was a disaster, and is now the subject of a class action lawsuit. So really, very, you can see how complex her presentation is. And, you've got to wonder, when did her chronic pain start? Was it the injury at work, or was it just a slow build-up as a result of all those small t traumas over her life? And, in terms of treatment, where do you really begin? Past, present, or even future? And although, again, I'm not psychoanalytically oriented primarily or anything, but I liked what Freud said here when he talked about it's our relationships with others. I don't know, he was specifically alluding to attachment problems, but that's the thing that really sets the ground for the development of chronic pain in response to whatever else happens in a person's life, as the previous case illustrates. And regardless of whether a person has experienced attachment deficits and whatever other trauma, the fact is that people are different. And some of us are more emotionally sensitive than others, and the impact of attachment problems and life stresses is going to be greater for those individuals than perhaps for the quote-unquote the average person. So I always include in my assessment an assessment of personality and what sort of, does this person have an anxious disposition? Are they sensitive? How do they deal with feelings? So this is Piaget's model of trauma, including not just the event, but predisposing factors in personality. Genet felt that some people were more prone to dissociation and hysteria, as medically unexplained symptoms were defined than others, as a result of a quote-unquote weaker nervous system. Quote-unquote, the hysterical personality cannot cope with full reality. It screens out material without being aware that it's doing that. Associated with that, there is a narrowing of consciousness due to a lack of psychological strength. And then that leads to, basically what they call fixed ideas, trauma-related patterns of thinking, feeling, and behaving. So then you see at the bottom, you've got psychasthenia or hysteria. So psychasthenia was an early term for neurosis and depersonalization. It's associated with a loss of reality functioning and a lack of energy. So the person might want to do A or B, but they just don't have the energy to do it. In contrast with hysteria, the person has actually energy, the fight-flight response producing energy, there's agitation, but they cannot focus or set goals or have any direction. So there's sort of mismatch between energy and their ability to function. And there is actually quite a lot of work done on the role of personality and pain from various approaches. So, for example, in the psychodynamic literature, they talk about a person's hysterically organized or neurotic or dissociative. Also, the concept of harm avoidance, which simply means that a person avoids novelty or change, so they have a very fixed way of looking at the world. In schema therapy, it'd be associated with disconnection or rejection schema or impaired autonomy and performance. In hypnosis, chronic pain may be associated with increased hypnotizability, which really means increased suggestibility. Paul Dell describes something called the auto-hypnotic model, which literally means that some people really deal with stress through dissociation. That's their default mode of coping, and that's about 15% of people, which is about how many people are highly hypnotizable. And it's consistent with this. PTSD sufferers actually do have higher hypnotizability scores, and that's associated with conversion disorders, somatization, and ultimately complex PTSD and DID. Dell actually recommends routinely assessing hypnotizability in clients with dissociative disorders. So I'll be talking more about hypnosis later in the course. Dissociation is the essential process in the production and maintenance of trauma or stress-related pain. Sandra Paulson actually has stated that dissociation is the engine of traumatic sequelae and somatization, not the caboose. So really assigning primary importance to it. And of course, we generally understand dissociation as a disconnection between mental, sensory, and emotional elements of experience. But it's way more complex than that, and there are much more manifestations of dissociation than that. Dell has identified 5 key manifestations of dissociation. Survival-oriented or evolutionary dissociation, so just concealing one's vulnerability as a way of surviving. Depersonalization, dissociation potentiated repression, so just amnesia or denial. Intrusions from dissociated structures, so feelings breaking through from the EP. And normal dissociation and conversion disorder. So I'm just going to look at these in a little bit more detail in terms of how they play out in the production of chronic pain and medically unexplained symptoms, so that you'll be more easily able to recognize dissociation when assessing chronic pain clients, because of course by definition it's invisible. It's about their attempts to hide what's really going on. So Holmes and Dell and various other dissociative experts have kind of broken the dissociation down into 2 processes. One is detachment and separation, that sort of parsing of sensory, emotional, and physical elements of experience, which is the most commonly understood definition of dissociation. And secondly, compartmentalization, which is kind of the end product of dissociation, where a client's personality is actually divided into ego states that handle different elements of experience, and somatization. So each of those two kind of primary processes of dissociation is responsible or associated with different dissociative phenomena. So with detachment and separation, we're looking at we've got avoidance, depersonalization, and amnesia. And with compartmentalization, or amnesia, ego states, and somatization. And all of those dissociative phenomena, or many of them, will be present in chronic pain sufferers, and they're all maintaining chronic pain, not directly so much other than in intrusions from ego states, but in the sense that they're maintaining a person's level of stress and tension and pain. They're inhibiting them from acting in their own behalf, and from dealing and releasing with trauma that's being held in the body. So I'm just going to briefly take you through these one by one, just to have a look at how they actually play out and maintain chronic pain. So avoidance is, of course, about minimizing one's exposure to stressful or painful situations. And the aim of avoidance, essentially in dissociation, is to shield the person from negative, overwhelming experiences. And in the short term, of course, it's an effective strategy. But in the long term, it's associated with never really dealing with anything, not resolving things. There is no processing, no flowing, no moving on. So, the price of avoidance is that nothing changes. The person lives in a state of stasis. and that basically ultimately maintains their pain and their health problems. A lot of chronic pain sufferers are suffering from depersonalization, not necessarily a depersonalization disorder, but a loss of connection with themselves, a loss of their sense of themselves. And this can be as a result of other life trauma or attachment problems, but also just pain itself. As Canadian hypnotherapist Marlene Hunter says, pain is a dissociative experience. It separates us from what's going on around us. So you can imagine that if a client has a trauma history and then they also develop chronic pain and have to deal with that, that's kind of a double whammy in terms of their sense of self, and they, not surprisingly, they're going to experience a level of depersonalization as a way of coping with that. So D.H. Lawrence, the famous writer and author of Sons and Lovers, and who also suffered from tuberculosis and died in his early 40s as a result of that, he struggled a lot with his health problems and gives one of the best definitions of depersonalization I've ever seen. I'm only half there when I'm ill, and so there's only half a man to suffer. To suffer in one's whole self is so great a violation, it is not to be endured. So you'll see this sort of level of depersonalization in just about every sufferer of long-term illness, trauma, chronic pain. There's just that sense of reduced connection with self and reality. It's very normal and very typical, but can be very, very stressful for the client who doesn't understand that. Again, it's just a dissociative response to actually help reduce their exposure to unpleasant reality. Depersonalization can also be caused or triggered by the way medical institutions treat chronic pain sufferers. Doctor, I want to choose how I'm treated. You're not just ill, you're deluded. So, just that unfortunately all too common phenomena where people are not treated as people, they're treated as diagnoses or objects or recipients of medical procedures who aren't allowed to have any voice. And again, D.H. Lawrence had something very accurate to say about this. So, of course, D.H. Lawrence, with his tuberculosis, and this is nearly 100 years ago, was acutely aware of the limitations of medical institutions, and he was actually quite actively seeking alternative health treatments, and was way ahead of his time in doing that. But I think his words are still relevant. I went to the scientific doctor. I realized what a lust there was in him to wreak his so-called science on me and reduce me to the level of a thing. So I said good morning and left him. Again, you can just see the depersonalization happening there. Amnesia can be a product of avoidance and or compartmentalization. It involves, of course, a loss of autobiographical memory. There are basically two types of amnesia: vertical and horizontal. So vertical is basically repression, where negative material is buried in the subconscious, whereas horizontal is more that the painful material is stored in another room. It's kind of horizontal in the sense that it's not really forgotten, it's just stored in the, for example, the EP or the repressed child part. And of course, the problem with amnesia is that it leads to a disconnection between memory of past events and present reality, and a decreased ability to apply the lessons of past painful experiences to present life. So, of course, amnesia does not directly cause chronic pain, but it maintains pain through separating the client from past and present reality, inhibiting the ability to integrate and learn from past experiences and apply them to their present lived life in a way that maintains their safety and health and well-being. So we're moving into compartmentalization now. So that's kind of more the end product of avoidance and separation of the experience. And with compartmentalization, we see the development of ego states or parts which hold different, basically bundles of thinking, feeling, and behaving, with each part responsible for different aspects of experience. So the ANP or manager part, to use the IFS terminology, is responsible for everyday functioning, whereas the EP or the exiled child holds the feelings, the affect, the painful memories and vulnerable states. And the thing about ego states is in an untreated client is that they're not integrated. So the client's either one or the other, but the two are never in the room at the same time. So of course the problem with ego states is that they again tend to preserve those traumatic feelings and memories whilst enabling the client to function relatively normally. Different ego states will be associated with different behaviors and responses, sometimes involuntary. And again, there's just this lack of integration between the conscious and unconscious parts of self. And again, this is something you'll see in every chronic pain sufferer, just because of what a person has to do in order to cope with chronic pain, and of course the effects of long-term trauma. And again, the purpose or the function of ego states is to enable a person to be able to function in the world without their vulnerability being obvious and a source of harm to them. And the last point was just normal somatization or even conversion disorder, depending on how seriously traumatized the person is. So somatization is, of course, anxiety manifesting as physical symptoms. And the fifth dissociative phenomena that's implicated in the maintenance of chronic pain is somatization. Now that can be everything from just mild everyday somatization, chest pains or tension or pain in the gut, to more serious problems such as fatigue, irritable bowel syndrome, and in more extreme cases, conversion, where the kind of somatic symptoms are actually represent manifestations of unprocessed, dissociated, traumatic pain, bodily symptoms, and in more extreme cases, things like pseudo seizures. Now, as Janina Fisher points out, dissociation involves, naturally enough, changes in brain functioning, particularly an increased reliance on left hemisphere functioning. So while the right hemisphere is in a state of fight-flight, the left hemisphere is able to maintain a semblance of normal functioning. And I'm going to show you what that looks like in terms of behavior, how in a way it actually in the long term actually exacerbates emotional responses, behaviors that maintain pain. So a Scottish psychiatrist by the name of Ian McGilchrist wrote a book a few years ago called The Master and His Emissary, describing the differences between left and right hemisphere functioning and how that plays out in terms of personality. And I just want to summarize these and then show you how increased left hemisphere functioning can actually maintain and exacerbate chronic pain. So left hemisphere functioning, or Apollonian as it's known in hypnotic terms, Apollo referring to the kind of god of doing, involves a kind of more narrow focus of attention. It's less flexible. The left hemisphere prefers the known world. It doesn't deal well with novelty or newness. That's what the right hemisphere is all about. The left hemisphere tends to live in a more decontextualized, disembodied world. So it's the world of the mind. It deals with information in a kind of logical, analytical way, sequential processing. The left hemisphere, in terms of personality, tries to create itself or the person based on what it can achieve, what it can control, what it can do. Whereas the right hemisphere, it lives in a more relational world, and the self comes from interactions with others rather than things that the person has achieved unilaterally. And so on. The left hemisphere tends to be more competitive, more exploitative in its relationships with others, and it's kind of more prone to frustration and anger when it doesn't get its way. In contrast, the right hemisphere, which is also consistent with the Dionysian personality, more pleasure-seeking, more embodied, more living in the here and now, involves more open, sustained attention than the left. It's more flexible. It's more open to experience in the here and now. It lives in the world of flow, of spontaneity, of mystery, of tolerance for ambiguity, a world that one can explore, that is never fully known. It's a more embodied kind of way of living. It can deal with a kind of different kind of realities at the same time, different experiences. It's a more relational kind of approach to life. It's more comfortable with metaphoric, symbolic languages and concepts, more empathic in its relationships with others, but also somewhat more prone to depressive emotions. So those are the differences between the left and the right hemisphere. Nobody is all one or the other, but I suppose the agreed. No one is all one or the other, but we're all a bit of both. Sometimes a little bit more left, a little bit more right. Some people, regardless of whether they've suffered trauma or not, will be more left hemisphere. Some will be more right hemisphere. There are kind of tests that can measure that. So the problem is that while the left hemisphere likes to live in its known world where it's in control of everything and there are no surprises, it comes at a cost in terms of the person's ability to engage with reality, to absorb new experiences, to change and adapt and evolve. So left hemisphere kind of dominance tends to be associated with alexithymia, disassociation, disconnection from emotions. Cognitively, it's associated with sticky thinking. So when when a person with left hemisphere dominant thinking, if you like, that they tend to be more wedded to their thoughts and perceptions, rather than responding spontaneously to what's happening in the here and now. And when they get an idea in their head, it's quite hard for them to let go of it. Of course, there's decreased attention to the body and unrealistic expectations, of what the body can achieve associated with that. Poor pacing, workaholism, lack of self-care, not resting or seeking treatment when they need it, are often associated with attachment issues, so looking to themselves for, to fulfill all their needs rather than trusting or relying on others. Again, poor emotional regulation, because really they really want, the left hemisphere wants to control emotions. It's disconnected from emotions. It's not really engaging with its own emotional self in an integrated or connected way. It's harm avoidant, and that really comes from what's called the known, living in quote unquote the known world rather than the lived world. So I'm going to open that up a little bit more for you now. So harm avoidance is a psychoanalytic concept, and it's the end product of left hemisphere dominant thinking and dealing with reality. And it's about living in the known world and being disconnected from the lived world, and really being closed off to new socio-emotional learning experiences which are necessary for normal experience-dependent growth of the right brain and personality development. So while left hemisphere dominant functioning and thinking protects the organism from being overwhelmed by the emotion and trauma that's stored in the right hemisphere, it comes at that cost of being disengaged with the lived world. So, in summary, dissociation shows up in chronic pain sufferers in a number of ways. The reason it's important is because dissociation is one of the key factors in the production and maintenance of chronic pain and medically unexplained symptoms in trauma survivors, which is most chronic pain sufferers. So you need to know what dissociation looks like. It's not always going to show up in a DES, for example. And secondly, in addition to being able to recognize it, because your clients aren't going to tell you explicitly, it has implications for your treatment, which we're going to talk about a bit more in detail shortly, but just a bit of a heads up now. So if a client is displaying a lot of dissociative symptoms, even if they're not of a DES or clinical level, they're likely to need safety and support prior to trauma processing. Just for example, if the client's manifesting as having ego states, then they may well need ego state work before being able to do EMDR processing, because if you're trying to do EMDR processing with a trauma and there's a part that needs that pain in order to be safe or meet some other need, then the EMDR is not going to work. And last but not least, it's the involvement of dissociation that will indicate the need for ego state work, possibly hypnosis and other approaches in addition to EMDR. And that's really the basis of the whole phase-oriented treatment approach. So just to conclude, again, dissociation is the key to understanding the link between trauma and pain and how your clients are dealing with it. It's something that is often not visible, but by being aware of the different ways in which it manifests in your clients, you can understand how they're coping with their trauma, why it's manifesting as pain, and what sort of treatment inputs you need and in what order. Now, I'm not a big questionnaire person, but these are a few of the basic questionnaires that I give to most of the trauma pain clients that I'm treating. The first thing I give all clients before I even see them is my pre-interview intake questionnaire. So I get them to fill that out and return that to me before our first session. And that questionnaire, which you would have received a copy of in your handouts bundle, assesses strengths, resources, personality, as well as trauma history, presenting complaints, and what the client's seeking from treatment. So when the client comes through my door, I already have quite a lot of content and information about them, which I'm able to match up, of course, with my personal, experience of them, and kind of get to treatment much more quickly than sort of having to spend all that time just taking the history and finding out what's happened. Now, of course, you're not going to get all the history in that intake questionnaire, even though sometimes you'll get quite a lot. And in fact, some clients say very little, and their responses are very minimal. But that also is information, and it sort of gives you the clue that this person may not be as ready for treatment as they think, or that they've got some trust or safety issues, and you can look out for that. The other questionnaire that I give a lot of my clients is the Mind Styles questionnaire, which again you would have got a copy of in your handouts. It measures hypnotizability, but it also, even if you don't do hypnosis, it gives you information about the client's openness to new experiences, and it's kind of a bit of a sneaky peek at whether they're a left or where they fall on the left-right hemisphere spectrum. So clients with low hypnotizability tend to be more left hemisphere dominant, more analytical, kind of more concrete in their thinking, and less able to concentrate on and absorb new experiences. It doesn't mean they can't participate in EMDR or benefit from hypnosis, but just that they have a more rigid intellectual style, and probably you're going to be working more slowly with them emotionally. I give most of my clients some sort of trauma screening questionnaire, perhaps the PCL or the Impact of Events scale, and a DES, again noting that it's not not a guaranteed instrument for detecting the ways in which dissociation can be present in chronic pain sufferers. As some of you may be aware of the MID by Adele, which is available online. It's a 200-item questionnaire, but it's a very comprehensive screening instrument for dissociation. So you've taken a history, you've assessed whether the client's dissociated, not so much whether, but how it's manifesting in them, and you're now ready to decide whether the client is ready or suitable for EMDR, or they need some other input prior to that. One of the key criteria we expect in trauma processing and look for is how stable the client is, and that goes without saying. But another very important factor in chronic pain sufferers is their energy levels. So a lot of chronic pain sufferers are suffering from psychasthenia or fatigue or exhaustion. They're in dorsal vagal shutdown, and those clients need not only stabilization and resourcing, but they need help to develop energy prior to participating in EMDR. And clients who are in a shutdown state are often in a state of arousal. So the more exhausted, shut down, tired a client is, the less likely I am to begin with EMDR. So I'm going to show you in a minute what the ideal EMDR client is, which is not what most of your trauma pain clients look like. So this is a description of the ideal EMDR client, and this is not your average trauma pain client. It's someone who has suffered a single incident trauma with one identifiable target. They may have if they have medical problems, it's relatively simple. It's not chronic. It's not complex. It's not having a major effect on their life functioning. It's the onset is more recent. They have not been in pain, for 10 or 15 years, which a lot of my clients have. They're generally stable, and they have safety in their present life and their circumstances. They have access to energy and affect, and there is no secondary gain. They're not afraid that there's something wrong with them that hasn't been diagnosed. There is not some ego state that needs the pain in order to survive. So that's your perfect, just start up, EMDR clients, sit down and start EMDR after you've done the history and the assessment and set up your targets. But that is very uncommon when working with chronic pain and medically unexplained symptoms. So in terms of your ideal EMDR client, it is someone who maybe has chronic pain, but is otherwise generally healthy. They might have some simple medical problems. They might have suffered a single trauma. There might be some not too severe attachment issues, but generally they're what we'd call a clean skin, and they've got energy and stable affect, and basically a good supportive family. And just to give you an example of how much you can do with EMDR and a client like that, Schneider and Hoffman in 2007 in the EMDR journal described EMDR treatment of a man who had lost his leg in a motorcycle accident in Germany. The leg was amputated at the hip. Of course, he had PTSD, had quite a bit of medical treatment and a lot of phantom limb pain and some traumas associated with his medical treatment. And all they really did with him was 9 sessions of EMDR. And at the end of those 9 sessions, he was off all the opiates. His trauma had been resolved. He was ready to embark on training as a Navy diver. And I actually wrote to one of the authors and said, how was this possible? And basically it was possible because the guy had nothing else in his life. He had a good marriage, he was healthy, he was stable, he was integrated, he was well adjusted, and that enabled him to process a trauma and pain as severe as that with nothing more than EMDR. Of course, that involved a bit of resourcing, a bit of future template, but essentially all they did with him was EMDR. Whereas if you have a client who is got more of a chronic trauma history, perhaps including emotional neglect and abuse in childhood, severe attachment issues, complex medical issues, then you're going to need more than EMDR in order to effectively treat that client. And you're going to need to think about the order in which in which you deliver those inputs. So this is how I conceptualize a phased approach to treatment in trauma and pain sufferers. It's very similar to Phillips and Frederick's 1995 SARI model. In fact, it's virtually identical. I just realized that they were so similar after I developed it. So I'm acknowledging them for those of you who might be familiar with that. So basically, what are you looking at here? Well, essentially, the concentric circles indicate the level of complexity of the client and the kind of where and when to bring in treatment needs. So if you imagine that the whole wheel represents the most sort of severe, complex presentation as per the previous slide, then your treatment would really start with the therapeutic relationship, with developing attunement, resonance, safety, and building a safe place for the client to explore their trauma and feelings. then of course resourcing them, helping them, to learn to manage their feelings, perhaps their pain, and then you might bring in a bit of EMDR, and really, I highly recommend hypnosis for, really, especially for helping the client to deal with pain, but it can also be useful where the client can't remember the trauma that might be associated with their pain, or other conflicts, or sort of secondary gain that might be maintaining their pain. Then you come to, then when you've got safety and stability, and the client's having some resources for managing their negative feelings and pain, then they might be ready for trauma processing. And that's really where EMDR comes into play. And again, sometimes hypnosis for help, particularly for helping to access the trauma, where the client's amnesic of it. And finally, not any less important, is integration. And that really is when you do parts work to help bring the parts into co-consciousness and working together, the AMP and the EP, or the protector and the exiled child, so that not only are the symptoms resolved, but you're helping to create a fully integrated, functioning person who may have some ongoing pain and disability, but has a positive sense and an integrated sense about themselves as a result of that. So that's kind of my template. That's the process that I'm guided by. It's not black and white. Sometimes you might be doing trauma processing and then having to go back to resourcing, or a therapeutic relationship, or doing parts work. It's not an ABCD thing. It's something that's fluid, that's changing depending on the client's needs on any individual day. But generally, the more complex the client, the more as you'd be familiar with the phase-oriented approach, the more you'd begin with therapeutic relationship, resourcing, safety, and stabilization. So we can't really talk about safety without considering Porges' polyvagal theory. And chronic pain trauma survivors are usually vacillating between fight, flight, and shutdown, both of which are attempts to deal with overwhelming stress, and both of which can maintain and exacerbate chronic pain. As you can imagine, with the fight-flight response, there's increased tension, hypervigilance, insomnia, fatigue, sometimes anger, and all those things can maintain pain. Whereas with shutdown, again, fatigue, exhaustion, lack of motivation and energy, metabolic changes, and just decreased ability to deal with pain. So safety shows up in both ways, and even they're not sort of mutually exclusive, really, because clients who are in a shutdown state have, I read somewhere, been found to actually, to be also in a hyper-aroused state. So they're not necessarily mutually exclusive. So just reiterating that point, that clients who are in a hyper-aroused state are experiencing bodily sensations more intensely and have more difficulty containing them. Whereas clients who are in a shutdown state are again interpreting bodily signaling differently, and in a way that maintains and exacerbates whatever they're feeling in their body. And that quote is from an article. The second quote is from an article about the polyvagal theory and fibromyalgia. And apart from the effects of trauma and pain, I guess a frequent contributor to safety issues is that of third-party involvement, insurance companies, medical institutions, and so on. And these organizations, if you like, have a vested interest in basically minimizing often the client's reality, their suffering, their treatment needs, in a way that can be invalidating of their experience, and is certainly not genuinely often geared towards really understanding and addressing their treatment needs. So whenever there's third-party involvement, the client's often in conflict between their reality and the sort of feedback they're getting from the medical institutions and system. And the client's almost put in a position where they actually, have to exaggerate their symptoms in order to get believed. But of course, this isn't what most trauma sufferers are inclined to do. In fact, they've spent most of their lives minimizing their symptoms and trying to appear less vulnerable than they really feel. So it's at this point that that coping strategy of avoidance and denial can actually really work against them. And unfortunately, even our own profession hasn't been immune to patient blaming and mischaracterization. And I think we have to be very careful with approaches that emphasize, the patient taking responsibility for their pain, which can easily slip into patient blaming, which is why I like the trauma-informed approach, which recognizes that in many of these clients, survival has depended upon them taking responsibility not for themselves, but for everybody else at the expense of their own needs. And in order, for them to actually act on that injunction to take responsibility, they're going to need to deal with their trauma and its effects on their, identity, structure, and personality. And thinking about the experience of chronic pain sufferers, the amount of invalidation that they experience around their pain, regardless of what other trauma they may have suffered, one is reminded of Judith Herman's statement that it's that inability to acknowledge and express the reality, or talk about the reality of what's happened, that is one of the things that makes traumatic experiences so traumatic, and certainly inhibits the individual's ability to work through it. So just think of the victim of child sexual abuse who's threatened with dire consequences if they talk about it, or who's afraid to talk about it for feelings of shame and not knowing how the adults in the room are going to react. It's a very similar dynamic. And this is actually a slide that I kind of recreated from a presentation I went to a few years ago by a psychiatrist who was talking about chronic pain, and he said this is the thing that chronic pain sufferers need the most, and by extension trauma sufferers. And of course we all do that. I think the point, I think, is that it's not just the validation that comes in the therapeutic relationship, it's actually really translating that validation into self-validation. And clients with trauma and chronic pain often have a lot of self-doubt about the reality of their experience and their symptoms. And so yes, validation is important, vital, lovely, but in a sense it won't take unless it's accompanied by some sort of ego state work. Okay, so we've worked through history stage, the preparation stage, thinking about safety issues, particularly in terms of the effects of present pain on clients' current life functioning and stability. We're now really to look at really the assessment phase and the targeting options. There are 3 primary targeting options, and in fact really only 2 to begin with, and they'll be either trauma or present pain. Generally speaking, you're only going to be looking at effects of pain after you've dealt with one of those 2 first. Now, generally speaking, as EMDR therapists, the first thing we're doing is looking for past memories, float back, trauma memories that are potentially the basis for the client's current presenting symptoms. Now, we all know in reality it often turns out to be way more complex than that. There may be layers and layers of trauma on top of attachment problems, present safety and stability issues. So I like Roger Solomon's, he made a statement a few years ago that it's actually really important just to consider what the client is ready for. And it's certainly in terms of, where there's significant present pain, that is going to be your primary target, because that is a safety issue. It's the dominant issue. The client's not going to be able to think about childhood trauma while they're in that state of overwhelm and pain and discomfort. So it's always client-centered, and I just want you to think about present pain as a potential target when you're working with this clientele. So you're used to the 3-pronged approach: past, present, and future. And again, just this point that you have to assess, the client's needs and base your targeting and your EMDR on what they need most from you right now. And if they're regardless of the trauma history, if they're in a lot of pain, they're probably going to need to address that first as a safety issue with EMDR or hypnosis or some other forms of resourcing. And they're certainly not going to be thinking much about the future in those early phases of EMDR. You've really, really got to be flexible and client-centered in your creation of targets and your application of EMDR. And by the way, it's morning here in Australia, so if you're hearing some weird bird sounds from left stage, that's the crows. In terms of targeting, and in addition to trauma and or pain, eventually, probably not initially, but sooner or later, there's going to be you're going to have to work with perhaps fear of pain, feelings of worthlessness, medical trauma, self-doubt, and so on. And that image that we all saw in our training about a trauma and associated channels, which is just isn't as neat as that. And when you're treating chronic pain, there'll be multiple target nodes, each with different associative channels, some overlapping and interacting, some separate and different. And it's just way more complex, multi-layered, past and present. I hope you're getting a sense of that by now. In terms of your TICs, your target, your image, your cognition, your emotion, and your sensations, the key point is that you're going to probably need to think about organizing that or structuring that a little bit differently to the kind of linear way that we associate with the TICs. So the TICs often looks a bit different, especially if you're working with present pain. So you'd start with a sensation instead of an image, because there isn't a memory. If you're working with present pain, although there may be other traumatic memories there, you're not working with that, and that is not directly part of your present target. So you don't have an image, that's associated with a memory. So you need to construct one based on the present felt experience of pain, the sensations. So what size, shape, color does your pain feel like it has? If there was an image associated with that, what would it look like? So the order's a little bit different. Got to be creative here. Then you get your negative cognition. I don't usually bother with a positive cognition. It's just too hard for clients to get. Much easier to backload it once the client's feeling a bit of relief. A negative cognition in the usual way, and then it's not really necessary to actually ask what emotion do you feel when you think of your pain. It'll be obvious that what the client's feeling, but you're actually not targeting an emotion that's associated with a past memory. You're targeting their present sensations. So it's just, in my experience, it's cumbersome and it adds an unnecessarily extra element. You're working with the present felt sense of pain and discomfort, and you can do that quite effectively without needing to obtain, what do you feel when you think about that? So I'm going to share with you a short clip of a colleague who kindly volunteered to be part of a demonstration. He's suffering from present pain. There is no trauma associated with his pain or other trauma in his life that he wanted to talk about in relation to this anyway. He's grappling with some diagnostic issues around his pain and the effects of the pain. So now that you've had I think a fair bit of information about what sort of things to look out for when you're assessing and preparing a client for EMDR treatment of pain, I want you to put in some of this into practice now with 3 different chronic pain presentations. One is a woman with a ruptured disc who has a fairly complex medical history, not to mention other life trauma that you can take for granted that are present, although not discussed in the video. Another one is a woman with fibromyalgia who also has some sort of trauma that she at least alludes to in the video, and last but not least, a lady with whiplash trauma of pain following a motor vehicle accident. So, and I want you to grab now your case conceptualization exercise questionnaire, which and I want you to watch each of these clips and answer the questions on that questionnaire as best you can. In terms of what we've been talking about and your assessment of each of these clients, the relevance of the trauma history, what evidence there is of trauma, medical diagnosis and presentation, correlation between their present pain and any medical diagnosis, whether there are potential safety issues, if they're ready for EMDR. If they are, what targets you might select. If they're not, what other treatment modalities might you introduce, and hopefully this will give you a bit of a chance to put into practice some of what we've been talking about this morning. So here we go with the first video. A woman with ruptured disc, very complex treatment history, and fairly obviously some medical trauma happening there. Now, I'm assuming that you were completing the questionnaire as you were watching the video, but if you didn't, hit pause now and just take whatever time you need to finish completing the questionnaire. And here are the answers, or at least what I think was going on. Did the pains these are the key elements of the case: complex medical She's got multiple small t trauma associated with that, and she's got safety and support issues. In terms of the specific questions, did this pain start with a specific trauma? Well, no. But again, with that medical history that she's describing, there's plenty of small t trauma, arguably some of them bigger t. Is there a significant medical history? Absolutely. She's had these multiple surgeries. She's been dismissed and invalidated. There's gender discrimination she's experienced, delays in treatment, failed treatment, the fusion, medical trauma, and being told that she'd be permanently disabled, which I think arguably is a big T trauma. To what degree is the pain medically unexplained? Well, in this case, I think there's an adequate medical explanation for her pain. In terms of her personality traits, does she, what sort of personality does she present as? Well, I think she presents as actually quite a balanced person, despite how much pain trauma she's experienced. And by balanced, I mean in terms of, left and right hemisphere, head and heart, her emotional self. She has quite appropriate emotional responses, and in a way, actually, I think contains her feelings and her trauma very well. She's quite resilient, and I think quite resourced, very intelligent woman. I didn't get the sense that she was highly dissociative. Does she feel safe? I don't think she does in the sense of the way she's been treated by the medical profession, so I think the therapeutic relationship and giving her validation and creating an environment of acceptance would be really important for her. Is she ready for EMDR? I think probably she'd be ready for EMDR fairly shortly, because she just presents as so stable considering what she's been through. I don't think she'd need an awful lot of preparation in order to start processing, but if I wasn't sure, I'd just ask her. Would I target her pain first or her trauma? There are several options there. You could target her medical trauma, her present pain, or the trauma of being told she was permanently disabled. I'd just ask. I really ask her what she wanted to work on first. At some stage, she's going to need ego state work, because she says things like, I pushed myself way too hard. And I think some somatic work, just learning to listen to her body. But I don't think that's where you'd probably immediately start. So that's the first case. So the second case is a young woman who's suffering from fibromyalgia. So I just want you to watch the clip and go through the case conceptualization exercise questions, just answering them as best as you can in terms of, likely trauma associated with the onset of a pain, significant medical history or health problems, what diagnosis she has, sort of personality presentation, safety issues, readiness for EMDR, and so on. Okay, so again, if you haven't finished completing the questionnaire, just hit pause and take a moment to do that now. And here's what I think responses you'd be looking for. First of all, did the pain start with a specific trauma? It's not clear, but she does allude to a bad relationship and other things going on in her life before the onset of her symptoms. She's quite traumatized, I think, by that night when she woke up with the heart palpitations and couldn't breathe. I don't know that that's a big trauma, but it's certainly a small t trauma and very stressful for her. there's certainly an allusion to there being a lot of other life stresses, if not big T traumas. Her unexplained pain is obviously very stressful to her. Medical history, she does allude to a history of migraines, and then of course, there's the waking up with the choking symptoms and the burning in the throat and the feelings of strangulation, and the body tremors and so on. She, I'm not sure if it's in the video clip because I'm only showing you a bit of it, but she did have Epstein-Barr virus in the history, which is often associated with later problems such as fibromyalgia and chronic fatigue. Just for your information, quite possible that she has generalized anxiety disorder as well. That also goes with things like glandular fever and or earlier viral illnesses. She's had 2 years of being in pain and not knowing with her, so that's a major element of the history and stressor. In this case, the pain is definitely medically unexplained. We'd have to say, and that's regardless of whether or not she has a diagnosis of fibromyalgia, because fibromyalgia is by definition there is no actual medical test or blood test, as far as I know, that you can make a diagnosis based on. It's more based on the symptoms. Personality, I'd say that she's actually quite left hemisphere dominant, dissociative, not necessarily DID or in that sense of structural dissociation, but she's certainly got evidence of ego states, and that sort of there's a disconnection between mind and body, and you can see that in the way she talks about her symptoms and her experience, and in that sort of disconnected way. Does she feel safe? No, but I'd say it's mainly down to her, to the effects of her symptoms rather than, other sort of threatening life circumstances. Is she ready for EMDR? Although she's fatigued, I think she actually has enough energy for EMDR. She's quite agitated. There's evidence of quite a bit of energy there, and I think she would benefit from targeting her present symptoms and obtaining relief from them. She does not want to work or talk about past trauma. She wants someone to help her feel better, and I think she would respond well to targeting her fatigue or her pain with EMDR without necessarily needing to or wanting to go back to past trauma. And in fact, she would abandon therapy if you tried to do that. She just wants symptom relief, and I think she would get that fairly immediately. So that's how I'd work with her. And then once let's say that she responds positively to targeting her present pain, then she might become more engaged and willing to open up and talk about other emotional stresses and traumas. Her negative cognition, if you were targeting present pain, would be, there's something wrong with me. And these are the key elements of the case. She has medically unexplained pain, which is always suggestive of, you're dealing with a disease of stress. You're looking at someone whose body has been through a lot of wear and tear, and who's developed symptoms as a result of that. There's always going to be some sort of dissociative processes going on there. Again, not necessarily DID or anything, but bodily symptoms being as a manifestation of severe stress or trauma. The body remembers. It's a classic case of that. She certainly had a lot of stresses, small and possibly big T trauma. But even if she hasn't had a big T trauma, small T, multiple small T trauma is enough is enough to produce post-traumatic stress levels of anxiety. There's certainly evidence of ego states there at the very least in terms of dissociative phenomena, not to mention avoidance. Don't know that she's amnesic so much, and certainly somaticizing. And last but not least, I think she, although she is aroused, there's sufficient stability. She's willing, there for her to begin to work with EMDR immediately. And as I said before, that's the only way this treatment is going to be successful with her. She's not looking to dwell on past trauma, and she doesn't need to. Not at least in the beginning of treatment. She will ultimately, of course. So the third case is a woman who's developed whiplash following a motor vehicle accident trauma. On the face of it, a fairly simple trauma and pain case that you might think is perfect for EMDR, but let's have a little bit of a look and see if things are as simple as they seem. So again, if you need a little bit more time to finish completing the questions, just hit pause now before I share with you what I think is going on with this lady. Okay, so yes, there's definitely, in terms of the first question, yes, there is absolutely a trauma associated with this client's pain. So we can say that. Is there a significant medical history? Yes. She's had delayed treatment. She's had problems with treatment, and the treatment has been ineffective. And also, she's now been pressured really to go back to work and to function more than she is physically ready for. Is the pain medically or unexplained? Well, yes and no. The scans show nothing, and in actual fact, whiplash pain is often isn't something that there isn't any detectable physical pathology. So there's kind of a bit of a gap there between her pain and her, I suppose, what shows up on the scans. In terms of personality, I think she's quite left hemisphere, quite dissociative. Certainly there's evidence of ego states. I don't think she's DID. I could be wrong, but and you might want to assess that more thoroughly. I think that would be a good idea. But I know, it's the trauma experts say, you've got to do that proper workup. You can't just rely on your gut feeling about whether people are DID or not. But anyway, there's certainly some dissociative phenomena happening here, and this is she's a person, I think, who relies on left hemisphere dominant thinking. I base that not just on sort of rational, analytical way she looks at things and speaks, and the dissonance between the way she describes her experience and the sort of distancing about her emotions. But you can also just see that in her presentation. She kind of looks quite put together. The neatness of the setting in which she's sitting. So, personality assessment isn't just something that's based on what the client says or their responses to a questionnaire. It's based on the whole presentation, the way they dress, the way they talk, how they talk about their feelings, and so on. It's a holistic thing. Does she feel safe? Well, I don't think she does in terms of her trauma and her pain. I think the pressure she's under to go back to work makes her feel, perhaps not overtly not safe, not in a way that she would acknowledge to herself, but there is a safety issue there. She's continuously having to fight for her rights and her needs. I think she has an anxious disposition. Is she ready for EMDR? Well, I think EMDR would have been good immediately following the accident, but unfortunately, I think it's too late now. Her pain has become chronic, and there's too much stress and anxiety. The treatment issues, the third-party involvement. So I think, you could try EMDR, but really she's in a bind between meeting her responsibilities and doing what she needs to do in order to take care of herself. And that unless that's addressed first, I don't think that EMDR is going to be terribly successful. She needs something to help her feel that she has more control and more safety, and then to be able to release the tension that she's holding in her body, and that I think is maintaining her whiplash pain. So what I would do is I would let her ventilate and create a therapeutic relationship. I would try and set up some boundaries to protect her from the pressures that she feels to perform physically when she, and really just needs to attend to her pain and her trauma. So trying to help create a bit more safety for her, where she can manage the demands of her work and her treatment providers, and prioritize her own health and well-being. I'd be doing some resourcing, perhaps some EMD to help calm her down physically, maybe some hypnosis and imagery to not so much to manage the pain, but as to uncover the meaning of the pain. If the pain could speak, what would it say? And give her access to her own unconscious. I'd be doing some parts work, probably before EMDR, and asking her perhaps her A&P to stand down a little bit and make room for her EP and her feelings. I'd be probably doing some somatic work. As I said, I think the other key factors in this case are that she has an anxious disposition, high need for responsibility, those ego states that we've alluded to, high need for control. You can hear the EP, in statements like, "I didn't choose for this to happen." It's hard. She says it's hard for me to relax. She's very compliant, does everything that's expected of her. But again, what does she really need? Needing to get into contact with her. Key elements of the case. So the key elements are trauma, unfortunately the problematic medical history and treatment, and the dissociative aspects in terms of ego states. So hopefully by now you've got a good sense of how to assess and prepare clients for EMDR, or if they're not ready for EMDR, to think about other treatment modalities that you're going to do first. And really how to sort of thread your way between trauma and present pain in terms of targeting and preparation for EMDR. So now we're ready to look at EMDR processing and what's different about that, and what how it looks and feels different, what you do differently when you're working with clients with chronic pain or medically unexplained symptoms. Just in terms of your negative cognitions, when we're working with trauma, it's very common to get negative cognition themes, themes of safety, lack of safety, and vulnerability. You will get themes like that when you're evoking negative cognitions of chronic pain, but you'll also get themes of lack of control and power, and responsibility and feeling defective. And that last one is quite common. And in terms of the effects of pain, you'll get negative cognitions associated with feeling defective. There's something wrong with me is a very common one, and that cognition can be about the way the client feels about themselves because of being in chronic pain. But of course, it can also be, or beneath it, behind it, will be earlier memories, traumas, associated with feeling defective, because of attachment issues or childhood trauma. So that cognition can have quite a bit of significance in addition to the client's present pain. The other rule, I suppose the other principle I'd say is there's no hard and fast rules. I find that whatever the client volunteers, as long as it's relevant in terms of their present pain experience, that's all that you need to for the processing to be effective. You don't need to be, I think, too precise about getting the perfect negative cognition in order for EMDR processing to be effective, whether you're working with past trauma or present pain. And as I've mentioned, it's perfectly okay to backload the positive cognition, and in actual fact, that's probably what I do the majority of the time when I'm treating this clientele, because they just find it so difficult to find, let alone ascribe any belief in a positive cognition at the beginning of treatment. So after the client's feeling better, more in control of the pain, and they've sort of perhaps reached a plateau of change, I backload the PC, and just by asking, so when you first came to see me, you were feeling pretty overwhelmed by your pain, but based on the changes you've experienced, what would you say about your ability to cope with it now? And when the client has experienced some change and they're realizing that that's possible, they just find it so much easier to volunteer a positive cognition. And of course, you can then rate it with a VOC and so on, and install in the usual way. Now, in the desensitization phase, there are a number of differences, variations in how you apply bilateral stimulation, the use of continuous auditory bilateral stimulation. You don't have to do that, but this is a variation that I use a lot and have found effective, which I'll explain shortly why. Much more active tracking and facilitating of the effects of bilateral stimulation than you're taught or used to doing in the treatment of trauma. And just the the idea or the notion that in many cases the pain is not going to be completely resolved, and that's not abnormal, and doesn't mean that treatment's a failure if it's not, and what to do about that. So the first variation, continuous audio bilateral stimulation, which you can of course obtain from an app or an audio recording, or some of the EMDR technology that incorporates that. Certainly clicking your fingers is not a sustainable option. So why audio BLS? Well, I think it's more visceral than eye movements, and Sandra Paulson agrees with me on that. So that's one thing, and this is really if you're dealing with present pain. If you're dealing with a traumatic memory that is perhaps associated with the pain, eye movements is fine. Secondly, why continuous? Because it maximizes the potential for sensory effects, and the need for that is because pain, whether it's medically related or not, often takes a bit longer to shift than simple trauma. So continuous BLS gives the client longer time to kind of engage with the dual attention bilateral stimulation. You get more of an entrainment effect. There's just better flow than stopping and starting every 30 seconds. What do you notice now? And of course, it gives more of a chance for the sensory gains to accumulate. So for lots of reasons, continuous audio BLS, I think, drives treatment more effectively. Last but not least, it's more adaptable for self-use. So clients, with persistent pain, you can give them a recording or an app which they can use for management of treatment-resistant pain or residual pain following EMDR. By the way, just thinking about audio bilateral stimulation, some of you are probably aware that hearing is one of the primary survival senses. It actually develops in the womb before sight, as you can imagine. And if you want proof of that, just think of what you do when you hear a plane fly overhead, or at night time you hear a fireworks display. I don't know about you, but I have to look up, even though I know it's a plane. And I have to go to the window and see where that fireworks display is happening, even though I know it's a fireworks display. And by the way, I like fireworks displays. At the end of the day, you don't have to do continuous audio bilateral stimulation. And it's strange with EMDR how what we seem to like doing works best. But just think about it and experiment with it. Be willing to experiment. The other variation is that you've got to track and facilitate the effects of bilateral stimulation much more actively, I think, than we're kind of taught to do in the standard EMDR training. And as I've mentioned, the reason that this is important is because the changes can be much more subtle and slow in coming, especially when working with present pain, than when working with simple trauma. And because of the presence of dissociation and alexithymia, clients are not necessarily very good at identifying and reporting, more subtle changes. And if they, if they don't notice, perhaps a subtle change in the pain or it's shifting, and they're going to say nothing when you ask them, what do you notice now? And then it's going to create the impression that the treatment's not working when it actually is, and it's going to stall your progress. So if a client says nothing, I actually take a more suggest a range of possibilities. I'll come to that in a minute. But paying attention to what's going on in the body, looking, listening, questioning, all right? Not just relying on the client's responses to what do you notice now. And as Bessel van der Kolk says, that phrase, notice that, or what happens next, is so important. Because you're directing the client's attention to what they're experiencing in their body. Having said that, and having said what I've said about, sometimes the client needing help with that, I think it also needs to be remembered that clients with trauma and pain can only, especially in the early stages, tolerate a limited amount of exposure to what's happening in their body. So, when we're talking about the body and bringing clients in contact with what's happening in the body, we need to do that in a way that's titrated and allows for, sometimes the client's needs to have a break from from being in their body and not what's noticing now. So it needs to be mixed with periods of rest, talk therapy, and other things. So you're sort of dancing with the right hemisphere. None of us live in our body all the time. So the aim is to help the client live in their body enough to integrate, the effects of bilateral stimulation or other sensory input in a way that they can learn and feel better, but in a way that's, paced and sensitive to their capacities. So it's a balance between here and now experience and I suppose being more in their head. So the whole goal of treatment and everything we do in EMDR or whatever other treatments we're using is about helping the client develop a healthy relationship between mind and body, being able to listen to their body and make choices based on what their body needs in the present. So if you're going to help clients notice and integrate the effects of bilateral stimulation, you need to have a full knowledge of all the possibilities of responses to bilateral stimulation. And I think that you should print out, if you don't, you should print out this list and stick it on your desk or your wall in front of you, because it's a lot more than is taught. When we're taught EMDR, we get a list of negative and positive cognitions, but I can't remember ever seeing a list of potential effects of bilateral stimulation. Decreased arousal, decreased respiration, feelings of lightness, drowsiness, relaxation, and so on. Now people don't, of course, report on their changes in heart rate variability, but there's an infinite range of physical responses that can occur that may or may not be verbalized, and it's of great assistance to the process if you have an idea of what's potentially possible, and can take an active role in helping the client to notice that. And of course, associated with that, the different mental and emotional changes that they can occur, because those physical changes don't occur in isolation, and they're actually what permits those reductions in anxiety or emotional distress or emotional lability, labilness, if that's a word. That's that's what we're looking for when we're doing EMDR. And of course, decreased worry, and also with that, cognition. So by that I mean that when a client's feeling more relaxed and less traumatized following EMDR desensitization, it's not only an absence of the negative cognition or worry, but there's often an absence of cognition altogether. And they'll report, if you ask in response to the question, what does it feel like is going on in your head right now? They'll often report nothing, that it just feels kind of empty and kind of quiet. And if they don't, I'll say, do you notice that your head just feels kind of more empty now, or feels more quiet? Like there's nothing really going on much at the moment. You're just sitting in the chair, looking at me and wondering what's going on. And clients will say yes, and then I'll use that. I'll feed that back into them and saying, so this is what being in the present moment, being presently alert and oriented feels like. You're not thinking of the past, you're not thinking of the future, you're just sitting in the chair, taking in a breath and not worrying about things. And that's a state of present oriented integratedness that many of our clients have never experienced in their life, and it's a missed opportunity not to identify that and reinforce that awareness. And just continuing that theme of helping the clients notice what they're feeling in their body and reinforcing it. I keep going. I do circle back to the body a lot, and remind the client of the changes that they've experienced. And I use this statement, that's to sort of to do that. These exact words, more or less. You might notice feeling different in your body, that the pain seems smaller or further away, and that your mind is quieter, like there's not so much going on in your head at the moment. Just like you're more in the room, more together, more present, more whole, like your mind and your body are working more closely together now. And that's a state maybe you haven't experienced since you were a young child, or maybe that you've never experienced before. But this is a state that you can learn to experience more often, and this is a state that will help you to live in the world, in your body, in a more integrated and more healthy state of mind and body, and so on and so on. So I'm always, refreshing and reinforcing that integrated, balanced state of mind and body, not just the positive cognition, not just some sort of resource. Being present, being presently oriented, being calm, being alert, no more or less than is necessary for the present moment, is a resource in itself. So I'm just going to share with you a clip of treatment of a chronic pain sufferer whose symptoms are associated with generalized anxiety disorder. That's a problem that affects women more than men, in a ratio of about 2 to 1. Affects 2 to 4% of the general population, male, female, proportionately. It's often associated with, of course, extreme worry and low back pain, headaches, insomnia, and fatigue. It's also often associated with depersonalization and identity issues. 50% of irritable bowel sufferers have generalized anxiety disorder, so it's a disease of stress. 28% of chronic pain sufferers have generalized anxiety disorder, and 12 to 47% of chronic fatigue sufferers. Also, 70% of PTSD sufferers have generalized anxiety disorder, and 25% of generalized anxiety disorder sufferers have PTSD. Now, this client doesn't have PTSD, but what he does have is great difficulty in getting out of his head and into his body, and noticing what's going on in his body and being in his body. So really the purpose of this clip, as much as it's a great demonstration of EMDR, is to demonstrate and show for you how I track and facilitate the effects of bilateral stimulation, and how this treatment wouldn't have been nearly as effective if I hadn't been able to do that. So just before we start the video, you'll notice that in the video I hold my finger up like this. It's because I'd recently done the brain spotting training. It's not something that you need to worry about, or that I do regularly anymore. So notice in the video how his first sort of check-in response to bilateral stimulation is intellectual. He asks, am I doing it right? Completely disconnected from, the dual focus bilateral attention and any awareness of what's going on in his body. And also notice how the check-ins during the continuous bilateral stimulation, because they never stop, actually, allow him to become more engaged with the process as time goes by. And how I actively suggest possibilities, quite assertively at one point. Eventually, he reports finding it's quite hypnotic, and you can see at that point that he's really getting into the process. And by about the fourth check-in, he's actually giving, really starting to experience and notice some differences. The check-ins, the time between check-ins is kind of more rapidly because the video is edited, but usually it's about 30 or 40 seconds between check-ins, and there's no hard and fast rule, just based on a gut sense of some sort of balance between giving the client enough time for something to happen and not leaving it too long, both sometimes to prevent dissociation and or not so much a problem in this case, but sometimes even just their mind wandering off. And you'll also notice in this case the distancing effect, that he eventually describes his problems as seeming less important, and also the backloading of the positive cognition. So this is just a summary of kind of my tips for tracking and facilitating the effects of bilateral stimulation. The first one is timing, just finding that balance between mind and body, giving the client enough time to experience something, not leaving it too long or too short. Making sure that they're kind of oriented and present to what they're experiencing. The more complex the case, the more I'll hang back with EMDR in terms of actually commencing EMDR, particularly where there might be conflicted parts or some indication that the client's not ready for EMDR. If the client appears tired or overwhelmed, then I certainly would do some stabilization and resourcing before commencing EMDR. The second point, as I've already discussed, is just knowing what's possible and having an awareness of that beyond just what the client reports during your check-ins. Also being able to recognize signs and symptoms of changes through non-verbal indications such as changes in voice tone, posture, and so on. Sometimes paying attention to your own bodily sensations. If I'm feeling tired or uncertain about what's happening, then that's can be a good time to check in with my client and see what's going on with them. And again, as I've indicated, not trusting your client's ability to at least fully or accurately report the physical or mental changes that they're experiencing and respond to EMDR, and not being afraid to actively facilitate awareness of those changes. Sometimes it can be quite more important to make the first bilateral stimulation count. So I've had clients who are very skeptical about therapy and EMDR, and kind of ambivalent about being in therapy. And like with the lady with the fibromyalgia case, which we did as part of the case conceptualization practicum. If she was my client, I'd be wanting to make darn sure that the first time I did anything, that she noticed some positive changes, even if I had to actively do that. So, if I was treating someone like her, I would be doing quite a bit of preparation to make darn sure that my first setup was good, that I had a good target, that I had a target that she was going to, get a result with, and needing to do that in a way to engage her in treatment and make sure that the treatment was going to be effective, and that she'd be willing to hang around to get more out of it. Again, just the usefulness of continuous audio bilateral stimulation. You don't have to do it, but I find it effective. And the study I did in 2014, by the way, involving 11 chronic pain sufferers, was based on audio bilateral stimulation, and 9 of those 11 clients reported significant improvements and resolution of not only pain but also PTSD symptoms. So that study is in your reference list. And lastly but not least, just reinforcing those changes hypnotically. So that idea of helping the client not only to notice the changes, but making those statements about just noticing how you're feeling in your body now. You're sitting in the chair, you're not worried, you're present oriented, and you can learn to experience this way of being more and more into the future, and experience more confidence and relaxation and integration and so on. So we're going to start looking more at cases and what EMDR treatment of chronic pain actually looks like, beginning with a kind of fairly standard case example of EMDR in the treatment of trauma-related whiplash pain in an otherwise uncomplicated client. You're actually not going to learn an awful lot from this, but I just want to sort of show you what it looks like, and then what it really looks like as things get more complex. So this is a fairly straightforward case of trauma-related whiplash pain. Whiplash, she has great whiplash. Actually comes in 4 grades, from 1 to 4. 4 being the most serious, and she has a low-grade whiplash. It's not terribly severe. In terms of pre-existing trauma, the only other trauma she has is, and it's not insignificant, is that 3 friends were killed in a similar accident about a year ago, and they were actually on their way to visit her. There's some current stress in the sense that she's separated from her partner and they're living under the same roof, but it doesn't seem to be impacting on her that greatly. Otherwise, she has a stable, well-regulated personality. Her pain is within tolerable levels. The target is actually turns out to be the accident trauma rather than the pain as a result of her choice. Her negative cognition is I'm going to die, so it's a safety related cognition. The usual emotions, terror. Her SUDS is pretty well a 10 out of 10. And then you'll see the trauma processing, and along with that, basically the resolution of her pain. And she doesn't really mention her pain after the successful processing. Just before we come to the video, quick bit of background information about whiplash pain. So SCARE regards whiplash pain as the quintessential trauma pain kind of presentation. It used to be called railroad spine, so it's kind of a 20th century problem ever since people have been involved in high impact collisions. It's about 50% of victims of survivable motor vehicle accidents will develop whiplash pain, and that most will recover within 12 months. As I said, it can range in severity from 0 to 4. About 28% of sufferers will also have PTSD. It's quite also a high correlation with major depressive disorder and our old friend generalized anxiety disorder. It tends to be worse in clients who have PTSD and or attachment problems. As I said, SCARE regards it as a psychoneurological disorder. And definitely the earlier and you can treat it, the better. So this woman's accident was less than 3 months had occurred before this session happened. So the only thing really to comment on was that I just asked her, we've got a trauma and a pain presentation. Does she want to work on the trauma or the pain? So I just simply ask her that. I don't have to make that decision. And the only other thing to say really is you could literally have used the trauma protocol there just as effectively. And the third thing I want to say is that's she's really a perfect EMDR client. Relatively speaking, she's a clean skin, a stable affect, reasonably good health. No seemingly other major trauma, and not unfortunately is not typical. Most of my clients who present with chronic pain and trauma are much more complex, as we're about to see. And again, just to summarize, the trauma rather than pain really was probably her main presenting problem. The pain in her case isn't primarily or a symptom of any other serious illness or injury. Medical treatment was adequate. There's no big problems there. There's no undue diagnostic uncertainty. She's got no anxiety about there being something else seriously wrong with her. Again, her pain is within tolerable levels. Good health and general health and well-being. There's no conflicted ego states or parts that might have some need for the pain. And the pain is really, truly, primarily part of a traumatic memory. It's a somatic element of an unprocessed traumatic memory. And probably the last thing I'd say that was important here, as I've sort of mentioned already, is just that it's a recent trauma. So unlike the woman you saw, the whiplash case in the case conceptualization exercise earlier, it's very early on. She's not under duress to be going back to work or having treatment issues. So it's fairly uncomplicated. Just before moving on any further, I alluded earlier to that case that was a report of EMDR, the treatment of phantom limb pain by Schneider et al. Of the motorcycle accident survivor who had his leg amputated in the accident at the hip. And I just again wanted to just briefly review this case as an example of what's possible with EMDR even in the case of such a very traumatic, severe trauma and chronic pain. So, associated with his amputation and his accident, he's got, of course, PTSD, major depressive disorder. His phantom limb pain he rates as a 6 out of 10 at day and up to 10 out of 10 at night. But he, on the positive side, he's got nil previous trauma or adversity. There is a 3-year history of failed treatment, and at the time that he seeks EMDR, he's on bucket loads of opioids. And as I mentioned earlier, all that they did with him was EMDR, targeting the trauma of the accident, some medical trauma he had experienced, including nightmares he had during an artificial coma that was induced in the early stages, and also an incident where he was dropped by a nurse. You can imagine the pain of that. And of course the effects of the pain and his injury, not only the loss of his leg, but also his wife suffering a miscarriage because of the stress of the whole situation, and seeing his stump for the first time and realizing, thinking that he was damaged forever, and some future and social, present and future kind of life issues associated with his injury and disability. He can just see his different negative cognition themes associated with the different targets, safety, vulnerability, and responsibility, defectiveness. And after 9 sessions of EMDR, he's off all his opioids, his pain and trauma are resolved, and he's ready to train as a Navy diver trainee and, resume his life. Again, all possible because despite the severity of that trauma, he's actually quite a resourced, stable, healthy individual. Not unfortunately your typical trauma pain client. Again, why suitable for why suitable and why for EMDR and EMDR alone? Virtually single incident recent trauma. Pain is primarily trauma related. He's got good safety and support, good health. There's no evidence of dissociation or ego state conflict or secondary gain. It's nice when it's that simple. Okay, so the next case example I want to share with you involves EMDR treatment of medically related pain, but again, fairly simple, uncomplicated medical pain presentation, no other major trauma or complicating factors. So in the next clip you're about to see, presenting pain. The present pain is his main presenting problem. It's not overwhelming. It's not related to trauma or secondary gain. His medical treatment is basically okay, not complicated. There's no undue diagnostic uncertainty. He's got good general health and well-being. So this is, just to give you a sense of continuity also, this is a colleague that I did the case conceptualization with earlier, who has the sort of 2 different types of pain in his lower back. And again, if you just a few little tips or considerations, if you're just treating simple present pain, which you'll be lucky if you have many of those, but at least it's somewhere it's a starting point. You've got to take the usual history and find out what diagnosis and medical treatment they've had. Some assessment of the personality. The more sensitive the personality, the more anxious disposition, the greater impact even a slight, relatively moderate level of pain can have. In the treatment of simple present pain, your target options are really just pain, its effects, and the health fears. And you saw, all 3 of those played out in the case example. How ready are they to work on the pain versus needing resourcing or stabilization? Generally speaking, because of the relatively less impactful nature of it, you should be able to start work straight away on the present pain, and my advice is not to delay doing that unnecessarily unless there's a real indication that this client needs resourcing or stabilization first. Don't just do that because that's what the book says you've always got to do. You need to assess the client's needs for that versus their readiness just to get on with processing their pain. Of course, if the present pain is associated with some sort of injury or organic pathology, you've got to respect the reality of that, and just how much of the pain can be eliminated with EMDR. Maybe limitations on that. So that having realistic expectations that in such cases, partial relief may be all that's possible, and most clients are, they're not expecting miracle cures. They'd be happy with, 50% less pain, for example. And of course, as it gets more complex, you're more likely to need to integrate EMDR with other adjunctive strategies, such as hypnosis, which is one of my primary adjunctive strategies, and somatic focus and ego state work. So we've worked through the desensitization phase. We're at the point of installation, which can be, of course, the positive cognition, whatever theme it may have, but also it's going to, in anything but the most simple cases, it's going to involve the installation of resources for managing residual pain, such as antidote imagery, healing resources, and ultimately future template